Okay, so we're talking about head injuries. And I didn't prepare these slides, so hopefully I can cover these things and not sound ridiculous. But starting from the top, central nervous system injuries are 40 to 50% of all injury deaths. And of course, the primary mechanism for these type of injuries is motor vehicle crashes. And a lot of you have seen in your patients that the associated behaviors for these type of injuries are alcohol and drug use, incorrect restraints, so not wearing their seatbelts properly or not wearing them at all, no helmet, and team sports without protective equipment. So just a review of the anatomy from the scalp all the way down to the cerebral cortex, or the brain tissue. You have your bone and then the subarachnoid space, which is made up of vascular and cerebral spinal fluid. And then of course the brain tissue itself. And so when you think about the type of injury that your patient might have, think about where it might be found amongst those layers of tissue. And this is just a review. I'm not going to go over that. That's what your head looks like. You remember from nursing school. So there's two types of injuries that we see. Of course, the primary injury, and that's the injury that occurs from the initial accident, the actual damage that's done at the time of force. And then the secondary injuries, and those are what we as nurses are trying to prevent, the secondary injuries. And that's the worsening or the extension of that initial injury due to things like hypoxia, hypotension. Okay, and you can see the example there that someone who may have aspirated because they were drunk and fell down, hit their head, now has pneumonia and is having hypoxia issues, is going to have maybe a worsening brain injury from that. Okay, so the Monroe-Kelly doctrine, essentially this is talking about your brain is a fixed space. You have your hard skull, your fluids, and your tissue. And once something changes in that set of things, then you don't have a whole lot of leeway. So it's just saying that once you change something, something else is going to have to give. And usually what gives is the brain tissue or the fluid. And a lot of times when we see someone that has bleeding, that's impacting the space there. So what has to give? Usually the tissue. And when that happens, we talk about things like herniation or worsening of the injury. So our body is fairly smart, and it can compensate for things like a little bit of blood inside the brain, or a high blood pressure or a low blood pressure, and provide enough perfusion to the brain. But sometimes that can get lost in the injury, and so we lose our autoregulation. So essentially we have this thing called autoregulation, and that helps to keep the cerebral perfusion pressure constant over a wide range of blood pressures. But like I said, when patient is really sick, a lot of times we lose that autoregulation, and that's when they're usually in the ICU because the nurse is helping the body regulate the systems. Okay. So this is just kind of an example, and most of the patients that have head injuries, such as epidurals or subarachnoid hemorrhages, are usually in the ICU because it's a vicious cycle. And at some point, we have to try to control that cycle or break the cycle. So just to give you an example, say you have someone who has a head bleed and they have uncontrolled ICP. Well, that's going to lead to decreased cerebral perfusion pressure because there's not the capability for the blood volume to be there in the brain. So the body wants to compensate. So how does it do that? It dilates the blood vessels to the brain to provide more blood flow and to prevent hypoxia. But then that further increases the ICP because you have more volume in there. Or it could worsen the existing bleed because you're pushing more blood into a torn blood vessel. So then you're right back at the top with uncontrolled ICP. So at some point, there's a fine line between breaking that cycle. So, which is why these patients need to be in the ICU, and they need to have an ICU nurse. They need to have thorough neuro assessments. They need to have those changes reported immediately or as quickly as possible to the physician. And they need to have those things taken care of pretty quickly to prevent those secondary injuries which I was talking about. And then of course, then they'll be able to have the best possible outcome. So what can we do as nurses? So we need to know what our standards are for assessments, and we need to know what the findings might be for different traumatic injuries, and how we can identify interventions to optimize ICP and prevent that secondary injury, and then to discuss the plan of care for a head injury patient, and then review evaluation methods. So the standards for assessing a neurologically impaired patient, are a neuroassessment with the oncoming and offgoing RN, and with all transfers, whether it's to another, like to CT, or to MRI, or to a decreasing level of care or increasing level of care. So we really need to be giving each other a neuroassessment handoff to make sure our patients are safe. And that includes a GCS and a pupil check. And of course, if the patient's in the ICU, then inspection of the ICP monitor and what is happening with the ICP. So most of the time, our neuro checks are Q1 hour in the ICU, and then I think usually in the IMU they're every like 2 to 4 hours, just depending on how concerned the physician is about potential neuro changes. Okay, and of course you're going to be doing a neuro check if there's any changes, or you do any sort of intervention to fix your ICP. Of course, we want to have the head and neck in neutral position and the head abed at 30 degrees unless otherwise indicated. And a lot of times in the ICU patients, if there's no spine injuries that we're aware of, or that the physician is concerned about, they'll be sitting up a lot higher than 30 degrees to promote that postural drainage. So what is level of consciousness? So that is our earliest indicator of a neurological deterioration. And this is just kind of telling you how the brain functions to provide a level of consciousness, so you can kind of look at that there. But also we're looking at pupil abnormalities. And when you have a pupil abnormality, it's usually caused by some sort of pressure pushing on the optic nerve, or the nerves that are associated with the eye. And so we need to find out what is causing the pupillary changes. And then there can be motor abnormalities, and that's just talking about how the brain provides motor changes. So of course, if you have some sort of change to your brain, there's fluid, there's blood, there's a contusion, you may have some sort of motor response or abnormality. So what is the Glasgow Coma Scale? I'm sure that as you get report, you're like, it's a 15, it's a 14. So what does that really mean? It's made up of 3 components: eye opening, verbal response, and movement. So it's scored from 3 to 15. 15 is the highest you can have, and 3 is the lowest that you can have. So a lot of the patients that end up in the IMU or the PCU are those that have mild head injuries, usually a GCS of 13 to 15. And then the other numbers, they're 9 to 12 or 3 to 8, are usually ICU patients, because that's indicating that maybe something needs to be watched a little bit closer. So like a mild closed head injury patient with 13 or 14, they just might be a little confused, but they're able to follow your commands and they have good pupil reaction to light, but they're just a little confused. And those other ones, moderate closed head injury, like a 9 to 12, they may not be saying a whole lot, or they may just be kind of mumbling. They may have some sort of abnormal movement, or they may have 1 or 2, something wrong with their eyes. So just to kind of give you an idea. And then of course 3 to 8, anything less than a GCS of 8, usually they're intubated just as a result of not being able to protect their airway. Okay, so what can you do in your assessments to notice if the patient has early signs of increased ICP? So one of the things, of course, I'm sure you've all seen this, they're complaining of nausea and vomiting, or they have a headache because they bonk their head, or they may be becoming more confused, or they may be normal 1 minute and confused the next minute. So they could have a waxing and waning of their level of consciousness. You may see them become restless, drowsy, or stop talking altogether. Or they may even be subtle vital sign changes. So those are kind of things that you can look at as you're looking at your patient to see, well, does my patient maybe have a hidden head injury that they didn't catch? You know, now they're in the IMU and they need to go to the ICU or they need to go to CT. So we need to find out what's going on. So just keep those in mind. And of course, late signs of increased ICP are pupil changes, so a dilated or non-reactive pupil. So if you're seeing a pupil change, you're in trouble, big trouble. Stuff needs to happen really quickly, and that's why a lot of these patients that they're concerned about ICP, or they have bleeding in the brain already, they're in the ICU because that bleed can change pretty quickly, and then you'll see the late sign, unfortunately, which is a blown pupil or a non-reactive pupil. So just keep that in mind, that that's a late sign, and you need to be acting pretty quickly if you see dilated or blown pupils. Unresponsiveness to verbal or painful stimuli. They could have abnormal posturing, which is flexion, extension, or just no movement whatsoever. They could have changes in their respiratory rate and pattern. And then, of course, the majority of the time we see this in the ICU when a patient is close to herniation, and that is increased systolic blood pressure, widening pulse pressure, and a decreased heart rate, and that's the Cushing's triad, or the Cushing's response, what we call it. So that's usually what we'll see. So if you're seeing all that pretty quickly, you're in trouble. So looking at what they might find on a CT, what is your patient diagnosed with? An epidural, a subdural, interventricular hemorrhage, a subarachnoid hemorrhage, a midline shift, cerebral edema, compression or loss of basal cisterns. So it kind of helps you to know what exactly is going on with your patient. And I know in the IMU you may see some of these people that have an epidural maybe a couple days later because they're stable and their neurological assessment hasn't really changed. But that doesn't mean that they couldn't bleed again a couple days later. So it's important to kind of know, what does your patient have? And maybe what might the treatments be for somebody with what they find radiologically. So this slide is just kind of talking about mechanisms of injury, and where the injuries usually occur when you have a certain type of application of force. So you have the rotational forces, and that's kind of when you get your brain just gets spun around inside your head, and you have the shearing and twisting, or it gets rotated back and forth fairly quickly. So you have that shearing and twisting. And you may have heard the coup contra coup injuries, and that's mostly an acceleration and deceleration injuries, like a motor vehicle accident, or getting hit in the back of the head with something, or on the side of the head with something. You have that brain moving forward towards the front of the skull, and then moving backwards against the back of the skull, and you have injuries usually in the front and the back, or on both sides of the brain. So kind of the most mild injury would be a concussion, and that's a mild to moderate injury. And that's just a diffuse brain injury that really results in no identifiable lesion. So when they do a CT, they don't see anything. They don't see a bruise, they don't see nothing, no bleeding, nothing. And a lot of times, I don't know if you've seen anyone ever suffer a concussion, but they'll just have a brief transient loss of consciousness, or they may not have a loss of consciousness. They may feel dizzy, have a headache, nausea or vomiting. They're usually amnestic to the event, or they have some confusion immediately following the event. A lot of times they'll be like, I don't remember what happened. I just kind of got I don't know. I don't remember what happened. So possible loss of memory, and then these patients are usually either or. They could be the ICU or the IMU, especially if they're concerned that something might be a little more serious, or their GCS is less than a 13, even if they just had a concussion. Okay, so the next type of injury, a little bit higher than a concussion, is a contusion, and that's essentially a bruise on the brain. So if you have that coup contra coup injury where your brain gets pushed forward towards the front of your skull and then backwards, you can get a contusion. It's not necessarily bleeding, it's just like a bruise, kind of like a sprained ankle. You get swelling in that area, a little bit of bruising. And the majority are found in the frontal and temporal areas, usually from a blow to the head, or a motor vehicle accident, kind of where you're acceleration, deceleration. And these people, altered level of consciousness, they might be a little crazy or confused. They might be saying weird things. And they may have abnormal posturing, like flexion, extension, or even flaccidity. And sometimes these patients these contusions can become worse over 24 to 36 hours. So, The majority of the time these patients usually go to the ICU just for monitoring, but sometimes they're only there for just overnight and then they get bumped down to the IMU level of care. So it's kind of important to just be aware that these things can get worse over the course of time, and they'll usually want to have a repeat CT within 12 to 24 hours after that. So we're assessing that patient for increased signs and symptoms of ICP, which are, do you remember? Okay, think about it. So the next thing is a diffuse axonal injury. And this one as well, we can't really see on CTs. We don't really see any type of injury. There's no fluid that shows up. These are commonly referred to as similar injuries to shaken baby syndrome. That's what they get, is DAI. And I'm sure that many of you have seen a patient come to you with DAI. They have varying prognosis based on the extent of the damage. So what happens is that the shearing, there's a lot of shearing in these types of injuries. So the shearing of the axons and the neurons and also the blood vessels. So usually that's diagnosed through MRI or just the patient's assessment. So how do we assess this? What do they kind of look like? They're usually immediately unconscious, or they have a really low GCS on admission or acutely. And then that coma is just prolonged. They take a long time to wake up, if they're going to wake up at all. They usually have hypertension or hyperthermia. They're kind of your classic neuro patient where they have this, sweating, they're hypertensive, sometimes they're tachycardic sometimes. They're just kind of all over the place. And they have abnormal motor posturing. They're difficult to, it's a difficult injury to diagnose, the length of time that they will recover, like I said. Okay, so the next type of injury is an epidural hematoma. And this usually occurs, so where it happens is, going back to that anatomy, you have your skull, your bone, and then you have that thick covering over your brain, and that's your dura. So this injury occurs in between the skull and that thick covering over your brain. So epidural, above the dura. And that is usually associated with a fracture in the temporal area or the parietal area. And usually it's from a blow to the head, or they fall and hit their head, somebody hits them in the side of the head. A lot of times this requires immediate surgical intervention. And the outcome is usually good. If the person gets to the hospital pretty quickly and they evacuate the blood clot or the bleeding, they control the bleeding in the head, they usually have a pretty good outcome. So the most famous assessment probably for this type of patient is this lucid interval. And initially they'll have a decrease in level of consciousness. They might be confused or kind of appear almost as if they had like a concussion, a loss of consciousness. And then they'll return to almost normal sometimes, and then quickly deteriorate back to a loss of consciousness. Normally that happens within the resuscitative phase, within the first hour or 2 hours that the injury happens to the patient. But sometimes if we're hurried and it gets missed or something, could end up happening later. So sometimes we'll see a hemiparesis or hemiplegia on the opposite side of the hematoma, or a paresthesia. Sometimes you don't really see, they're pretty normal, and you just have to go by the CT findings. And then there's also the unilateral fixed or dilated pupil. Those are things that you might see of the epidural hematoma. So subdural hematoma, the next type of injury is going to be below the dura. So we're talking about that thick covering over the brain. It's just right below that. And there will be a collection beneath that. So usually collection of blood beneath that. And that usually results from the tearing of the bridging veins connecting to the brain tissue and that dura. And this one's not necessarily associated with skull fractures. And acute symptoms usually are immediate within the first 48 hours. Subacute, 2 days to 2 weeks. And then there's those chronic ones where they're elderly and they have a atrophied brain and they fall several times and they're okay for a while, and then they get more confused because they fell again and they just keep getting bleeds. Or they have abnormal platelet function, those kind of things. So an acute subdural hematoma, like I was saying, is the shearing linear or rotational forces. So usually a motor vehicle accident or an assault get hit pretty hard on the side of the head or in the back of the head, wherever. And usually they go down pretty quickly. They're just continually decreasing in their level of consciousness. Usually we'll see motor deficits, pupil changes, usually on the same side. And then a lot of these patients are come in with the GCS at or around 8 and usually require intubation. So here's kind of a picture of the anatomy of the difference between an epidural and a subdural hematoma. Okay. So basilar skull fractures. It's the next injury we're going to talk about. And of course, pretty much all these injuries can occur a wide range of ways, but usually we're talking about motor vehicle accidents or assaults or a patient falling and landing directly on their head with no attempts to stop their fall. So these are kind of what you might see in someone that has a basilar skull fracture. Periorbital ecchymosis, we call that raccoon eyes sometimes, or mastoid ecchymosis, the battle sign, which is that bruising right behind the ear, kind of along where the mastoid process is. You may see blood in the ear, hemotympanum, or rhinorrhea, so CSF drainage from the nose, or otorrhea, CSF drainage from the ear. And a lot of times, you might see these patients a couple days later in the IMU, and they still have that CSF leak from the nose or the ear. There's not a whole lot that they can do about a CSF leak. They just kind of wait for it to get better and hopefully prevent infection. So a way to know if it's really a CSF leak is to check for halo sign or presence of glucose in the drainage. And I don't know if you guys are familiar with the halo sign. It kind of, the drainage, if you look at it on a pillow or on a piece of gauze, it kind of looks like a halo. You'll see the circles, just like circles continuing to go out, and that's kind of what it will look like. Or you can take an AccuCheck strip and put a little sample on there and see if there's any glucose in it. Okay, so other traumatic brain injuries, subarachnoid hemorrhage and intracranial hemorrhage. And this is just a picture kind of giving you an idea where these are located in the brain, the cranial vaults. So intercerebral is actually inside the tissue, and then the subarachnoid is in between that very fine layer between the dura and the brain tissue. So hematomas, these are they're usually non-operable. It can't really do a whole lot for these. So how do we treat them? Usually we treat just through ICP monitoring, cerebral edema management, or a cranial window. So these patients are the ones that have the monitors. They'll definitely have a monitor, a ventric or a Camino, to really monitor their ICP. Or if it's bad enough, they'll take them to the operating room and remove a portion of the bone and allow for that swelling so the ICP doesn't go extremely high and cause additional damage. So again, we're trying to prevent that secondary injury. So there's your mechanisms: depressed skull fractures, penetrating trauma, or significant acceleration, deceleration. And the majority of the time, I would say that these are caused by significant acceleration and deceleration injuries. At least that's what we see. And then this is just a picture of what herniation looks like. And there's different types of herniation where the brain can herniate at, just depending on where the injury is. So that Monroe-Kelly theory, something has to give, and it's usually the brain tissue that gives, unless we're controlling the fluid, the blood, one of those, okay? All right, so how do we care for these patients? There's a list: fluid management, impaired mobility, altered sensory function. I'm just going to list these up here because you guys can figure it out according to what your patient needs, but here's just a list of some of the things that you can put for your plan of care. So a head injury patient, how do we intervene? What are we doing for these types of patients? So our primary objective, like I said, is to prevent the secondary injury. And the top 3 things that we do to try to prevent a secondary injury is to make sure that they are getting enough oxygen so they don't become hypoxic. We're controlling the bleeding, we're controlling their blood pressure, we're trying to maintain an optimal blood pressure to get enough blood flow to the brain. And we are doing what we can to control the ICP, whether it's just monitoring it, whether it's draining off some of the fluid, or whether it's letting the doctor know, hey, we need some medication, or this patient needs to go to the operating room. Okay. So just briefly, hypoxia, what it is, of course, it's just presence of apnea or cyanosis in the field, and that happens a lot. The patient will get hit and they don't breathe very well, or they lose their airway or something. A PaO2 of less than 60. So, if they're in the ICU, it's probably a good idea to pre-oxygenate these patients before you do any type of suctioning, just to help provide the optimal amount of oxygen before we suck it all out. So hypotension, single observation of a systolic blood pressure less than or equal to 90 in patients with an increased ICP. And it's a fine line that you walk between managing the patient's blood pressure to maintain an optimal cerebral perfusion pressure and controlling the ICP and all those things. So that's why these patients are in the ICU, because it's such a fine line. We use vasopressors, volume to maintain the mean arterial pressure. And then hypertension, of course, we treat those with our standard medications, labetalol and hydralazine. So CO2 levels are important, and they play a part in controlling the patient's ICP. There's been a lot of studies lately to not hyperventilate patients. They used to do that a lot in the past to help bring the CO2 level down, because when the CO2 level is low, it causes vasoconstriction. And that was to vasoconstriction and decreased cerebral blood flow. And they were hoping to, we're trying to control the components of the Monroe-Kelly theory where, something has to give. So we're trying to optimize blood flow and that. But now they're saying that it's just better to kind of let the CO2 be in a normal range and to not hyperventilate patients. So a lot of physicians will still kind of think that that's the best way, but it's a fine line. And it could potentially compromise the brain perfusion and worsen ischemia. So what is increased ICP? Usually, in order to know what increased ICP, with the monitors that we have, we're looking at numbers. So anything greater than a pressure of 20 is usually something that we start to get concerned about. So what do we do for an ICP that gets up greater than 20? What can we do? So, like you can do, even if you don't have a monitor, these things you can do as well. So check position. Is the patient have their head like kinked to the side and, blood flow can't drain as well? So we're keeping blood flow up into that in the brain area. And, so postural drainage. Is the head of bed greater than 30 if TNL spine is clear? If not, are they in reverse Trendelenburg so that they have some inclination to their head to allow for that drainage? We can decrease environmental stimuli, turn down the lights, ask the family to be quiet or ask the family to step out. And then, of course, analgesia or sedation per the physician's orders. Also, medications. We can give osmotic diuretics. And those, just remember your serum osmol before you start giving those medications. And then seizure prophylaxis, we don't really do that. It's not really indicated, but of course there is a risk for seizures when you have changes to, there's blood that's irritating the brain, or you have high ICPs. Of course, ensure normothermia. These patients tend to have fevers or be really cold, usually fevers. And then as a last resort, we can look at paralytic therapy and a barbiturate coma. And then these are just some of the nursing interventions. Don't forget about taking care of their eyes. Okay, so surgical intervention is another way we can help to control the ICP. And that they just would go in and evacuate the hematoma or cut out a piece of the cranium, like I said before. Okay, so when we are trying to make interventions with this patient, what do we need to do? We need to always address the issue, treat and notify the MD, especially if things are happening outside the parameters that they have written for. So if they said ICP needs to be less than 20, well then we need to be calling the doctor if those parameters are not being met, as well as, you know, if the MAP or the cerebral perfusion pressure is not within those set parameters, then we need to be letting the physician know so that we can make changes. And then of course don't hesitate to go up the chain of command, because sometimes the doctor will say, oh, it's fine, they're fine. So if you feel like that you need to go up the chain of command, don't forget you can. And you know, this patient's in the ICU for a reason, and that's because we're trying to provide the best care possible for the best possible outcome. So you always need to reevaluate your neuro exam after any type of intervention. So say you have high ICP and you give serum osmol, you need to recheck your neuro exam. Or if the patient has high blood pressure and you gave labetalol, you need to check the patient's neuro exam after, or reevaluate the patient after you do any type of intervention. And of course these patients require ongoing and frequent assessments, because they can be changing all the time. And the quicker and the more frequent that we do these checks, then the chances of catching something quicker or earlier and providing the patient a better outcome will be for their benefit. So we just need to document and assess any interventions, evaluations, and communication that you have with the physician, especially as it pertains to the patient's plan of care. And that is the last slide, I believe. Yes. Any questions? So I get to talk about spinal cord injuries as well. And are you guys ready? Okay. So these are just kind of the objectives of the things that we're going to discuss in this presentation. So the epidemiology of spinal cord injuries, review the spinal cord anatomy, discuss mechanisms, present types of injuries, discuss assessment findings, appropriate nursing diagnoses, and then other common interventions. So what is the spinal cord and what does it do? So if you remember from nursing school and your anatomy, that it sends motor information to the body and it accepts sensory information from the body. And this coordinates reflexes. And so therefore injuries to the spinal cord have serious medical and personal impact. If you have any questions while I'm talking, you can ask them too. Okay, so just as numbers, so you have an idea of the amount of spinal cord injuries there are in the United States. About 250,000 Americans are spinal cord injured, and 11,000 new cases each year. So how many of them do you think are male? And you guys probably have the answer there, but greater than 80% are affected, are males, and they're usually between the age of 16 and 30. And that has to do with the whole thinking that they're invincible during that age. So, and that they play a lot more sports and those kind of things. So mechanisms of spinal cord injuries, usually motor vehicle crash, violence, falls, and sports. So it makes sense that the majority of them are males because they're usually involved in those types of things. Okay, so this type of injury usually has a far more reaching impact, and because there's a lifetime medical care cost for just a paraplegic is greater than $420,000. A lifetime cost for a quadriplegic is greater than $1.3 million, and additionally greater than 60% of spinal cord injury patients remain unemployed. So there is quite a significant cost to our community, and the personal cost to the injured and their loved ones is of course immeasurable. So this is just pictures of the anatomy of the spinal cord and the surrounding bone. So you have your spinal cord and then the vertebral bones that surround it. And this is just, we're going to talk about mechanisms of injury, and so the most common of course is motor vehicle accidents. And you have this, sorry you can't see this very well, but it says the hyperflexion. So when you snap your head forward pretty quickly, you can cause some ligament injuries and of course the stretching of the spinal cord as well. Of course it goes as well the other way, hyperextension injuries. You get the same kind of thing where you can get breaking of bones that protrude into the spinal cord or just the stretching of the spinal cord in general. And this is supposed to show axial loading, and these are usually from patients that may fall from a height and land directly on their bum or on their spine, so you have that loading effect where all their weight is kind of impacted in their back. They land on their head, it's diving into a pool, shallow pool. These are types of those kind of injuries, axial loading. This is supposed to represent rotational injuries. So there you go. That would just be, of course, as it sounds, rotational. And I don't know what happened to the slide, but penetrating injuries, of course, get stabbed in the back and you have a transection of the spinal cord. So this just shows you up close. Same as with your skull and your brain, you have the layers, you have a dural and you have the subarachnoid space. You have this, everything from the head all the way to the spinal cord is encased in the same type of material, so it's similar. And then they're surrounded by the bone, of course. So you have very little room for swelling or any type of injury to take place before you start having problems with the actual tissue itself, the spinal cord. So the types of injuries. Remember, is it spinal column or is it spinal cord? Okay, so a spinal column injury can lead to spinal cord injuries without proper precautions. So a spinal column injury would be more the bone, the bony aspect, and then the spinal cord injury would be the actual tissue itself. So it's important to know your patient's injury and your patient's anatomy and the risks at hand when you take over that patient, because if they have some sort of bony issue and they move the wrong way, they could have just given themselves a spinal cord injury. Okay, so always err on the side of caution. So fractures in the spine are considered stable if there is no potential for progressive impingement or injury to the spinal cord. So there's no chance that that bone is going to get into the spinal cord area or move the bone into the spinal cord area. That's kind of going along with the second point there, that there's no potential for displacement of the injured bony area during the healing process. So if the surgeon or the physicians feel that there's a chance that during the 6 weeks this the bone is healing, that it can move or the bone can slip, they'll opt to go in and surgically fix the bone area. No displacement or anticoagulation from normal physiologic loading after the healing has occurred. So you want to make sure that the blood flow will be intact to the spinal cord area. So any type of vertebral injury along the spinal cord would be considered unstable as well. Loss of ligamentous integrity results in unstable spinal cord injury, and then if the ligamentous injury is predominant, the injury may remain chronically unstable. So say you have you pulled the ligament in your C6, 7 area, and they would have to wear a collar, or they would try to fix that, make it more stable. So vertebral injuries, and this is talking about the bone itself. So remember the anatomy of the bone, you have that large vertebral body, and then you have the transverse process that kind of sticks out. I always remember them looking like giraffes, kind of. And then the lamina and the spinous process. So a lot of times you'll get fractures along the spinous process, the lamina and the transverse process, and those they'll usually consider pretty stable because they don't usually impinge on the spinal cord. But you can see that if you get something close to the lamina, or it's a pretty big fracture in the vertebral body or lamina, then there could be potential risk for that being unstable and the bony fragments to go into the spinal cord. Okay. So this is just a picture of what a compression fracture looks like. You have that crushing of the vertebral body. And then sometimes the crushing can be so severe that you actually get pieces that get pushed into the spinal cord area, and that's what we're talking about. That would be an unstable fracture because that's impinging on the actual spinal cord area. Or it could actually have already caused an injury. Okay. So then this is just showing you what a burst fracture might look like. You have a lot of pieces sticking out, similar to that picture that we looked at before, where the pieces are kind of all broken up and can go into the spinal cord. Kind of self-explanatory. Vertebral injuries. Now, on this side of the body, on this side of the bones is the inside of your body. So that's where your heart and your intestines and stuff are, and then that, of course, is the little ridges that you feel along the outside of your back. So if you have a fracture on the inside there, there's not too much concern about whether it might get into the spinal cord, but there's always that risk. If it becomes free floating, it could cause damage to the spinal cord. So this is just showing you a slide of all the ligaments that are supporting the spine, and there are a lot of ligaments that make up our spine. And if those ligaments get stretched or torn, then you could have slippage of the bone into the spinal column, or into the spinal cord, or you could have stretching of the spinal cord itself. So that just kind of shows you maybe what, like a dislocation would look like. So the injuries are classified by the type and function, usually a direct insult or a result from a secondary injury. And just like in the brain, the spinal cord can have a concussion and contusions and transections, which we'll talk about. So concussion, same type of thing. It's just a temporary loss of function for 24 to 48 hours. And that's usually because the cord gets shaken pretty severely. So I'm trying to think of maybe an example of that, and I'll think for a second. So contusions, bruising of the cord. The only thing I think of is football players. A lot of times, if they get hit really hard, they could have a concussion or contusion, where they may have had some sort of stretching of their spine, and so that stretches the spinal cord and causes a concussion or a contusion. So we've had several football players come in and they've had just kind of that concussion or contusion. And then of course you have the transection, so the severing of the cord completely or incomplete. And complete is pretty rare, but it does happen. It's usually more physiologic transection that is the more common of the two. So physiologically, there's just that loss of transmission between receiving sensory and sending out motor. So how do we assess the spinal cord? After every manipulation, turn, or transfer, you should be doing a spinal cord assessment, especially with every manipulation or turn. With every change of caregiver, so oncoming, offgoing nurse, hourly in the initial post-operative period, or anytime there's a change or you do an intervention, you should be checking the spinal cord assessment. So of course, if you're receiving this patient, it's probably a good idea to get an idea of what maybe the spinal cord assessment or the spinal assessment was before you take over this patient from the physician. Say they went to have surgery. What was their assessment before they went to surgery? So you kind of have an idea where you're starting from, and you can tell if there's improvements or if there's a worsening of the injury. So continuing with the assessment, you're going to assess for motor function and sensory function. So what makes up the motor function is movement and strength. Just like with our GCS, we're testing for, how strong are they? Can they flex their arm? Can they, open and close their fingers? Those types of things. And then the sensory function, we're determining whether or not they can even feel us touching. So there's two components. A patient may be able to move but may not be able to feel, or they may not be able to feel but can move, or vice versa. I don't remember what I said. Sorry. So they can feel, may not be able to move, or they can move and may not be able to feel. There. So we're testing that. We're testing their ability to feel as touch stimulus. So usually how we do this in the ICU is we take a Q-tip and we break the end off and kind of make it a little pokier on the wooden side. And we, of course, doing this where the patient can't see what you're doing, and testing, is this soft, is this sharp type deal. And then, of course, what are we touching? Am I touching your knee? Am I touching your big toe? That also goes into the assessment as well. So you begin at the top and work your way down and be pretty systematic about it. And then this just kind of gives you the list of the scale. 0 is complete paralysis and 5 is normal strength. And these will all be listed on Epic. So as you're going through and filling it out, you can say, oh, this is what it looked like, and give it a number. And this is the spinal map, so it gives you an indication what nerves are controlled in what area. So see the cervical areas are everything from kind of your triceps up. Thoracic, use mostly your abdominal and chest area, and then lumbar is your leg areas, your leg muscles, and then sacral is, as you can see, bowel and bladder, and then sexual function. So where the level of injury is going to be where you start to see changes in your spinal cord assessment. Okay, so this just kind of says that C7, it's a crucial level. So that kind of is the level where it makes or breaks whether you're a quadriplegic or paraplegic, generally speaking. Okay. So this just kind of gives you an idea, goes through all these. I'll just kind of let you look at them. C4, diaphragm, C5, alive, we call. Deltoids, they're able to shrug their shoulders. So they usually have just gross motor movement. C7 is generally better. They can usually, use their arms more. Going down, S1, they can move their legs, anything in between their arms, or legs, quadriceps, ankle flexion. And then for the sensory, this is the dermatome map. So you can kind of see based on the nerves that innervate, that come off from the spinal cord area, where they innervate to, and where you might see the sensory changes. So if you have an idea of where the baseline is for where that patient can no longer has sensation, then you would start there and kind of go up or go down. Go up and go down to make sure that that's where the line is. Okay? And then check for proprioception, which is, what am I touching? Is it your elbow? What? Okay. So spinal shock. This is a reflexive component, and it's usually due to the loss of continuous tonic impulses from the brain, causing transient suppression of reflexes below the level of the injury. This usually occurs shortly after spinal cord is injured or damaged. So if someone has a spinal cord concussion, they may end up with spinal shock as well. So it can occur in the least of the injuries all the way up to the most severe of injuries. And you can see flaccid, so paralysis, an absence of the proprioceptive sensation, and loss of autonomic reflexes, and sensation of the reflex activity below the level of the injury. And then this just kind of, the intensity and duration depends on the level of the lesion, and this gradually resolves, so it returns to normal. So, shock, the neurogenic shock has a cardiovascular component, and it's usually associated with injuries at or above T6. So there's an acute phase, a loss of vasomotor reflexes, loss of sympathetic innervation, loss of vascular tone, vasodilation, decreased systemic vascular resistance, and decreased blood pressure, and decreased cardiac output, and decreased perfusion. So it looks very similar to any type of shock a normal shock that you would see. These patients are hypotensive, they may be bradycardic, and that's the shock. And that's just because the loss of the signals to the brain from the spinal cord, resulting in the shock. So, like I said, bradycardia and hypotension, because you have that inhibition between the sympathetic and parasympathetic flow. Okay. So, an example of these patients, not necessarily shock, but spinal cord injury patients, can vagal, they can block down their heart. They can vagal down pretty easily with stimulation, suctioning, coughing, those kind of things. So here's some nursing diagnoses that you can just kind of look at and keep in mind if you have a patient that has spinal cord injury. The biggest thing for spinal cord injury patients, of course, is ventilation and respiratory issues, and those are and infection. Those are the big ones. So because we're trying to prevent the secondary injury, most of our focus is going to be on those things, preventing, of course, further neurologic injury, but also the pneumonia and those things further down the line. So that's what's talking about, the systemic complications. So we need to keep a map of greater than 80 to prevent neurologic deterioration. And of course, full spine precautions. So seat collar, bed flat, neutral alignment, log roll, and then fracture pan for toileting. And I understand that you guys are going to be practicing C-spine and full spine precautions, so I won't go too in detail with that. But log rolling should have at least 3 people to turn and at the same time. That's what I'm going to say about that. So C-spine precautions, generally it's just the hard cervical collar. So a lot of times they have that, they'll have that orange styrofoam looking color. That's the Philadelphia color initially, and then hopefully if they do have an injury, they'll get switched over to our Miami J collar. And there'll be no pillow, and then of course just turn with C-spine under control. So it doesn't have to be 3 or 4 people at a time. And T&L spine precautions, the same as with full, except no one really has to be holding the head. You just have to make sure the patient can control their head. If not, then you should have somebody to hold their head. Okay, so care of the patient with the C collar, we just need to make sure that it's the proper size, because if we are trying to prevent secondary injuries. So if the patient doesn't have a proper fitting collar, they're going to get skin breakdown, and worse, they're going to have a further injury to their spinal cord. So we just need to make sure they have the proper size. And for cleaning purposes, you remove one portion of the collar at a time, so the anterior portion, and clean and inspect the skin, and then when they're during the log roll, someone is holding their head, you can take off the back and inspect the back. So I'm not really going to go over the road rest bed because you guys are talking about that as well. This is what it looks like, kind of, sort of. The picture got cut off, but you'll see it and you'll get to practice with it and use it. So I won't talk about too much. So these we don't see all that often. Gardner-WELLS tongs. I'm just going to show you what it looks like so you know what I'm talking about. Go back to the slide. This is just kind of traction for someone who may have had like a subluxation of the spine, or a spinal cord injury due to displacement. So this basically aligns the bones and helps relieve cord compression. So it kind of alleviates the symptoms of shock and whatnot, but it doesn't fix the problem by any means. So the injury has already occurred. Just ensure adequate pin care, analgesics, and the manipulation is to be done by the physician. And again, we don't see these very often. We usually see the halo. And I'm sure you guys have seen those in the past. So care of patient with the halo traction. We are not to remove the halo. We can clean the patient with the halo in place. For some reason, stuff gets underneath the jacket. You can remove that one portion at a time, just like you would the collar, just to make sure that it remains fairly intact so that we're not undoing what the purpose of the halo jacket is supposed to be for. In meticulous pin care again, and that's with usually betadine around the sites to prevent infection. And then of course you're going to be inspecting the skin at the pressure points. So, like I was mentioned before, the common causes of death in these types of patients are pneumonia, PE, and sepsis. So that is where our preventing secondary injuries is the most important. That's what we're trying to do. So administer steroids and solumedrol drips. So in the first 24 to 48 hours, we're trying to help reduce swelling to try to minimize the amount of injury that might be caused. Ensuring adequate cord perfusion at the level, especially at the level of the lesion. So good blood pressures, IV H2 blockers because of the steroids and the stress. Make sure they don't develop ulcers. DVT prophylaxis, whether it's an IVC filter or Venadines or heparin, whatever they're prescribed. So we need to assess the risk level of screening and treatment. And then of course the loss of intestinal motility, so whether they need to have an NG tube or be on neurobowel protocols or Reglan to promote intestinal motility. And of course maintain normothermia and meticulous skin care. So this just kind of talks about respiratory care, if they have a planned extubation, aggressive pulmonary toilet. So we are doing our best to try to prevent pneumonia with these types of patients. So we need to be aggressive as far as CPT goes, encouraging quad coughing, suctioning secretions, preventing aspiration, suctioning bronchs on occasion, and if they have a trach, doing good trach care and making sure that we're suctioning the trach to prevent infections. Of course, there's a psychosocial component. They pretty much, depending on where the lesion or the injury is, there's a loss of function, a loss of control. So we need to assist that patient and allow some control and early involvement of the other disciplines such as physical therapy, occupational therapy, social worker, and try to provide continuity of care. Of course, we need to involve rehab and case manager and those kind of things. So this is just kind of talking about how, you know, once again, we just need to make sure that our documentation is appropriate and that we keep the and that we're telling the story of the patient, and as things change, we're documenting those things, and we are keeping the physicians abreast of any changes according to our standards, shifts, between shifts, and across the levels of care. Well, that's it. Any questions?